paper about examining the COVID of 2019 novel coronavirus disease or COVID-19 pandemic on traumatic hip and lower extremity orthopedic case, systematic review and meta-analysis written by me and my friends.
Can you speak loudly, please? We can't hear you well.
Okay, I'm sorry. It's raining here, so maybe. Okay, I'm gonna introduce myself first. My name is Rida Asvinadalimunte. I'm a general practitioner from Indonesia. And now I currently work for 4 years as a doctor. And I'm also an assistant of orthopedic surgeon. So I have interest to be an orthopedic surgeon in the future. Thank you. Now I will start my presentation. The introduction is, can you hear me clearly now? Sorry.
Speak little loudly, please. Speak little loudly, please.
Oh, okay, I'll try. In the introductions, the COVID-19 outbreak is, you know, that there is a global pandemic caused by the SARS-CoV-2 virus, and this make us have to stay at home for a long time. And as the population is confined, there is decreasing in road traffic and the workplace and outdoor activities. But the domestic accidents like violence seems increase here, and the social changes have impact on the upper extremity injuries requiring emergency room. So when they have some cases and have to do elective surgery, they will suspend or like delay the surgery because there's no emergency in it. So in addition, the orthopedic science societies published for the orthopedic surgery during the COVID-19 outbreak and develop protocols whether the surgery is urgently to be done and which one should be delayed. This study was performed to evaluate the impact of the COVID-19 pandemic in activity related to emergency case in hip and lower extremity trauma, and specifically the surgical case. The material and methods, we did an extensive research was performed, including CINEHL Central from Cochrane Library and Medline or PubMed, and IMBASE like Science Direct, published up to January 2022. Following the preferred reporting items for systematic reviews and meta-analysis, guidelines using medical subject headings in terms hip and lower trauma and COVID-19. The literature search and selection process has performed by all the others carefully. And for the eligibility criteria, this is all accessible retrospective study written in English, studies evaluating the impact of COVID-19 to hip and lower extremity trauma case, and studies published in the past 3 years. The exclusion was inaccessible full text and irrelevant outcomes. The evaluated outcomes should include at least one of the following parameters like traumatic hip and lower extremity admission case, number of surgical case number, both measure as risk ratio with 95% confidence intervals. The data collection and statistical analysis. This was included based on eligibility criteria and assessed using the EndNote application for duplication. The quality assessment included study was performed using the Newcastle Ottawa. Study heterogeneity was evaluated using the IQ test. Heterogeneity above 50% was considered significant, so a random effect model would be selected for analysis. A fixed effect model will be selected if the heterogeneity was insignificant. So we consider a quantitative analysis as statistically significant if the p-value is less than 0.05. And we perform it using statistical software 17, and review manager 5.4 by Cochrane collaboration, Oxford, UK. Then I will show you the results. The article was carried according to Prisma guidelines. Initial study searching resulted in 128 articles, which all were processed using the EndNote application for study application. And from the inclusion, the remaining 92 studies were then assessed manually by all the authors. And from 28 articles were further analyzed for eligibility, resulting in 17 studies and analyzed for final qualitative and quantitative analysis. The study analyzed two outcomes: traumatic hip and lower extremity admission case and surgical case, both calculated as risk ratio. And there were dichotomous data. So 95% of confidence intervals were used for calculations. This is the first result for traumatic and lower extremity admission case. We can see that for the admission case, there was a reduced admission case because not much people going out, and if it's not urgently, they will just stay at home, and maybe they just ask for telemedicine to have a suggestion. There is the risk ratio here, and the CI is 95%. The risk ratio here was 0.85. And for the traumatic hip and lower extremity surgical case, the risk ratio is still, there's no decrease or increase in extremity and surgical case. There are still patients coming to the emergency department because maybe some people just need to come out, and then they had like road accident, like traffic accident like that. So they keep coming, and the risk ratio is, sorry, wait. So the conclusion is, the conclusion from this figure is there is no decrease on increasing in hip and lower extremity surgical case in trauma. So the discussion first. So we all know that the COVID-19 quickly spread around the world and become pandemic and make changes in healthcare delivery. So in the study, it's shown that COVID reduced the number of traumatic cases in hospital admission by 52.7% when compared to pre-pandemic period, especially for hip and lower extremity trauma. Also, as the discussion continue with Nunes et al. Reported a 78.6% reduction in traffic accident admission at a tertiary trauma center in Spain. And also the other study from Italy, UK, India, and USA confirmed these findings with similar data. These findings are in accordance with a study by Zhu also, which reported that the highest cause of trauma is due to traffic accidents on the road. And this and in our study, there was also a decrease in the number of sports injury that could be attributed the cessation of outdoor activity. And then the illustration by several articles that during the pandemic, people's activities outside home are notably reduced, while that the cause of the trauma cases in a hospital often comes from road accidents. Then from Guintoli et al. Shows 57.2% decrease in domestic accidents, but in the contrary to Andrea, according to Andrea, the number of domestic hand and wrist injuries increased threefold. It's likely this increase was owing to the fact that people spend more time at home. Besides, they might not seek healthcare due to fear of contracting COVID-19 if they come to the hospital. In this study, we also found that even though the number of trauma visits in the hospital was decreasing, there was a relative decline in surgical cases. In quantitative analysis, there is no significant difference in the pre-pandemic and during COVID-19 pandemic period for surgical cases. The conclusion is, during COVID-19 pandemic, there was a significant decrease in admission of patients with hip and lower extremity trauma when compared to pre-pandemic period, although the number of hip and lower extremity surgeries were not significantly affected. There are the references, you can see here. And thank you. I think that's all my presentation.
Variable presentations of systemic lupus erythromatosus, which is based on the presence or absence of anti-dsDNA antibodies. It's actually a case series which is done with 3 patients. I am a professor in the Department of General Medicine in Jagannath Gupta Institute of Medical Sciences and Hospital in Kolkata. Sir, can you see the slides?
Screen slideshow. Press the slideshow button.
Just a minute, sir.
Go to your right with your cursor at the bottom of it.
Slide control is there, right? I think that will.
Slideshow. Go to the bottom, sir.
Slide. That's the bottom, yes.
Bottom, go to the bottom. Go still down.
Achha.
Go still down. Press function F5.
Function F5. Function F5. Yes, sir. I pressed it. The volume is coming up, but.
No. Take your cursor down. Take your cursor down, sir. Still
Yes.
down, still down, still down, still down. Go down.
Yes.
Your cursor is not seen. Go to the full screen, no?
Full screen, just a minute, sir. Full screen.
Still to the right, where the circle is there, just to the right of that, bring your cursor there and it will start.
Oh, achha, yes, here.
Still go down.
Yes. I think.
That's it.
Yeah. Sorry. Extremely sorry.
Yes.
Yes.
No problem. No problem. Wonderful. Done.
Okay, thank you, sir. So, in the introduction, what is the difference between an autoimmune disorder and autoimmunity? Basically, autoimmunity is autoreactive B cells and T cells, but their presence does not cause any tissue damage, or it has got no pathogenic implications. But in autoimmune disorder, there is tissue damage and there are pathogenic implications. So my case series depicts the 3 cases of SLE based on the presence and absence of anti-dsDNA antibodies regarding their differences in presentations and their prognosis. And now, SLE is a connective tissue disorder with multi-system involvement. It produces different autoantibodies from polyclonal activation of B cells. Anti-double-stranded DNA antibodies, that is anti-dsDNA antibodies, are specific for lupus along with anti-SM antibodies. These antibodies are highly sensitive and specific, and they are the diagnostic hallmark of the disease. Their presence is actually very rare in healthy persons, so they are very important. The most important point is these antibodies may be present several years before the diagnosis, so a high clinical index of suspicion is necessary before we order any tests, probably with patients presenting with constitutional symptoms, with rheumatological symptoms, we can suspect. And these are associated with renal involvement with deposition in multiple places in the kidney like glomeruli, subendothelium, subepithelium, mesengium, and the basement membrane and tubules. The activation of B cells and T cells releases the pro-inflammatory cytokines, and the rise of the levels may lead to the relapse of the kidney disease. So the levels are also very important for the follow-up. Anti-dsDNA in lupus patients have higher chances of polysaccharide. And anti-SSA positivity are associated with Sika symptoms, that is dryness of the eyes, and anti-RNP is associated with Raynaud's phenomenon. Moreover, the low C4 levels link anti-dsDNA and complements in renal disease. Anti-dsDNA negativity with anti-SSA and B positivity have higher chances of presenting with cellulitis. So the differences in presentations may help us to guide. The series which is presented here actually depicts 3 cases of SLE with different clinical features based on the presence and absence of anti-dsDNA. So the first case, it's a 50-year-old non-diabetic, non-hypertensive female housewife by occupation who presented with dyspnea on exertion for the past 2 months without any history of fever, vomiting, loose motions, weight loss, and loss of appetite. There was no history of rashes, arthralgia, or bladder bowel symptoms. There was no history of bleeding from any side, nor any addiction or medication or abortion history. On general survey, there was mild anemia, petechial spots in the soft palate, which was a very important finding. Systemic examination, including examination of the joints, were unremarkable. A provisional diagnosis of ITP was made because of the petechial spots, because they appear earliest in the retina, followed by the junction of the soft palate and the hard palate. And the differentials were aplastic anemia and myelodysplastic syndrome. Investigations revealed mild anemia. Hemoglobin was 10 grams per deciliter with normal total leukocyte count, but platelet counts were reduced at 90,000 per cubic millimeter. Renal function tests were normal, that is urea creatinine, with mild transaminitis on LFT. Hypoalbuminemia was present with globulin of 3.3 grams per deciliter. Rheumatoid factor anti-CCP antibody were negative, but ANA was positive by HEP2 method 1:80 with homogeneous pattern, which was the entry criteria for considering patients of SLA according to the new 2019 ACR Euler guidelines. Anti-dsDNA antibody was positive by the ELISA method in ANA profile, but other antibodies were negative. Complement 3 was reduced with normal C4 levels. Within 24 hours, urinary protein was 1 gram per 24 hours. Serology was non-reactive, that is HIV-1 and 2 antibody, HBsAg and anti-HCV-RNA. And peripheral blood smear revealed normocytic normochromic anemia with normal vitamin B12 and folic acid levels. Other tests like USG whole abdomen, chest X-ray, and echocardiography were unremarkable, and bone marrow was done, which revealed increased number of megakaryocytes. Bleeding and clotting parameters were normal. A diagnosis of SLE, that is systemic lupus erythromatosus, was made based on the 2019 European League Against Rheumatism, American College of Rheumatology, Euler ACR classification criteria, where the score more than 10 is the diagnostic criteria. And here the score was 10 because the anti-dsDNA was positive, which was 6 points, low C3 was 3 points, thrombocytopenia 4 points, and raised 24-hour urinary protein was 4. So total 17 points as SLE is diagnosed with more than 10 points based on these criteria. Patient was started on oral prednisolone 60 milligram once daily. Platelet count started to rise 3 days after starting steroids and were normal day 10 after admission. When the patient was finally discharged and referred to rheumatology clinic, the patient is still under the follow-up, is doing well. Now, this is the case number 2, a 51-year-old non-diabetic, non-hypertensive female fruit seller by occupation presented with symmetrical inflammatory polyarthritis involving the metacarpophalangeal and proximal interphalangeal joints of both the upper limbs for the last 1 year. It's a pretty long duration of history, but things aggravated for the last 2 to 3 weeks, for which the patient came to us. There was history of generalized weakness for the last 8 months without any history of fever, night sweats, weight loss, loss of appetite, vomiting, diarrhea, and pain abdomen. There was neither any history of rashes nor any history of abortion. History of alopecia was present for the last 9 months without any history of dryness of the eyes. On examination, pallor was present with non-scarring alopecia. Systemic examination revealed pain on MCP and proximal interphalangeal joints with swelling and restriction of the movements. Other symptoms did not reveal any abnormality. Provisional diagnosis of rheumatoid arthritis was made as the morning stiffness was more than 1 hour with the differentials of collagen vascular disease. Investigations revealed low hemoglobin with 10.5 gram per deciliter. Total leukocyte count was low. There was leukopenia. It was 3,500 per cubic millimeter with normal platelet counts. Renal function tests and thyroid profile were also normal. ESR was raised at 40 millimeters in the first hour with CRP of 2 units per liter. Urine examination was normal and rheumatoid factor and anti-CCP antibody tests were unremarkable. LFT revealed mild hypoalbuminemia. Bleeding from clotting parameters were normal. USG whole abdomen, chest X-ray, electrocardiogram, echocardiography were also normal. Serum ANA was positive by the HEP2 method 1:80 and pattern was mixed 3+. ANA profile revealed positivity of anti-SSA. However, anti-DS DNA was negative, and the other antibodies in the ANA profile was also negative. And diagnosis of SLE was made by Euler SCR 2019 criteria, non-scarring alopecia 2 points, joint involvement 6 points, and leukopenia 3 points. So it was total 11 points, and it was diagnostic of SLE. Patient was started on steroids with clinical improvement. Now, the third case, the 31 years old non-diabetic, non-hypertensive female patient presented with photosensitivity and malar rash for the past 5 months with non-scarring alopecia for similar duration. There was no history of fever, night sweats, weight loss, loss of appetite, vomiting, and loose motions. There was no history of abortions, arthralgia, arthritis, and bleeding manifestations. There was no history of dryness of the eyes, dysphagia, that is swallowing difficulty, or neck swelling. Treatment, addiction, and menstrual history was unremarkable. On examination, there was a malar rash involving the bridge of the nose without any oral ulcer. There was mild pallor without any lymphadenopathy. Systemic examination did not reveal any abnormality, and a provisional diagnosis of collagen vascular disease was made. Investigations revealed mild pallor with leukopenia. Total leukocyte count was reduced at 3,700 per cubic millimeter with normal liver function tests and renal function tests. ESR was 20 millimeter in the first hour, and CRP was 3 units per liter. Chest X-ray revealed mild bilateral pleural effusion, and there was mild pericardial effusion on echocardiography. USG whole abdomen was also done, which was normal with normal PTA, PTT ion. Urine examination was also unremarkable. ANA HEP2 was positive at 1:80, and pattern was mixed with ANA profile showing anti-SSA positivity 2+, but anti-DS DNA was negative, and the other antibodies also did not reveal any positivity. Complement 3 levels were low, 0.7 gram per deciliter, normal being 0.9 to 1.8, but C4 levels were also normal. Diagnosis of SLE was made by Euler SCR 2019 criteria. Leukopenia scoring 3 points, pleural and pericardial effusion scoring 5 points, and low C3 3 points. Thus 11 points diagnosed SLE. Patient was started on steroids and hydroxychloroquine. Pericardial effusion improved after starting steroids, which is evident from figures 1 and 2. I will show you. This is the first figure, sir, before institution of therapy. And this is the second figure, which shows the clearance of the peripheral hydral congestions and the congestive cardiac failure. Now the discussion. Discussion is the SLE presents with variable clinical features. It is associated with different autoantibodies, with formation and deposition of immune complex. The new classification, that is the 2019 classification, reflects the pathogenesis of SLE and gives importance to ANA with high sensitivity and limited specificity. The 3 cases presented here had different manifestations. The first case presented as ITP with anti-DS DNA positivity and renal involvement. Serology was non-reactive in all the cases. ITP is a manifestation of SLE, and it was particularly important in the first case as skin manifestations were absent. So it was a diagnostic clue. So whenever we get an ITP, we do the hepatitis B, C, and the ANA profile. Platelet count improved with steroid therapy, proving that it's immunogenic thrombocytopenic purpura. The second case presented with symmetrical inflammatory polyarthritis, leukopenia, and negative rheumatoid factor. And anti-CCP antibody was also negative. ANA was positive, but anti-DS DNA was negative. But anti-SSA was positive. Patient did not have any renal involvement and improved on steroids. There was synovitis of more than 2 joints with swelling, tenderness, and morning stiffness of approximately 1 hour. So we are keeping a DD of rheumatoid arthritis and had done the tests of rheumatoid factor and anti-CCP antibody. The third case presented with malar rash and photosensitivity with ANA positivity, but anti-DS DNA was negative with anti-SSA positivity. Renal involvement was absent with the presence of leukopenia. ANA titer, now how it is diagnosed in the 2019 criteria. ANA titer more than 1:80 on HEP2 method is the entry criteria in the new classification, and its absence rules out SLE. Actually, the ELISA method we miss very often because there are many false negatives. So this ANA HEP2 method is the method of choice. When ANA is positive, additive criteria are applied, which if present even on one occasion, that is very important. If it is present, it may not be present, but it may come simultaneously also. Even if it is present on one occasion, it is sufficient to diagnose SLE with at least one clinical criteria with more than equal to 10 points. It also specified that the criteria may not occur simultaneously. That is also very important. It may come one after other, so causing diagnostic challenges. Clinical domains and criteria are: number 1, constitutional; Number 2, hematologic with leukopenia, thrombocytopenia, autoimmune hemolysis.
Yes.
Neuropsychiatric, such as delirium, psychosis, and seizure. Mucocutaneous, such as non-scarring alopecia, oral ulcers, subacute cutaneous lupus erythematosus, DLE, and acute cutaneous lupus erythematosus. Serosal involvement, pleural or pericardial effusion, and acute pericarditis. Musculoskeletal involvement, joint involvement, and renal means proteinuria more than 0.5 gram per 24 hours. And renal biopsy score. If renal biopsy score is suggestive of SLE, then that criteria itself is good enough to diagnose. The immunology domains and criteria are antiphospholipid antibodies, complement proteins, low C3 and or low C4, and SLE-specific antibody, that is anti-dsDNA and anti-Smith antibody. What is the utility of this new criteria? This new criteria actually tried to identify SLE at an early stage. So these cases highlight the correlation of renal involvement with anti-dsDNA positivity. The patients who had anti-dsDNA positivity had renal involvement, but the patients who had anti-dsDNA negativity, but they were lupus patients, they had usually skin manifestations, and polyserositis was also a manifestation in those patients. Hypocomplementemia was associated with anti-SSA in SLE patients, but antiphospholipid antibodies were absent in them, as described by the study by Aurora Mendenez et al., which was also evident in the case series. The patients who are persistently anti-dsDNA negative have polyserositis as an atypical clinical feature. So that's a clue. We should follow these patients to see whether they become anti-dsDNA positive. Though it is not mentioned at what intervals we'll do the anti-dsDNA levels, but we should follow these patients, because once they become anti-dsDNA positive, their implications will be same as the anti-dsDNA positive lupus. So the conclusion, the most important part of the case series is the lack of renal manifestations in the anti-dsDNA negative lupus patients with polyserositis in anti-SSA positive SLE patients with anti-dsDNA negative. So these patients have anti-SSA positivity, they have skin manifestations, they have polyserositis, which may be evident from the clinically also and also from the investigations. And the important part is, once we get an anti-dsDNA negative, the prognosis is good. But we should tell the patients that they should come at regular intervals to do the anti-dsDNA. If they are negative, it's fine. They will be termed as anti-dsDNA negative lupus. But if they become anti-dsDNA positive, then they will have the same implications as the anti-dsDNA positive lupus. And these patients of anti-dsDNA positive lupus, we know that it does not get cured. We have to maintain a low level of disease activity with the lowest possible dose of steroids, that is prednisolone less than 7.5 milligram per day once daily. And the disease activity score is also measured by the SLEDAI-2K index. And so the importance is follow-up of these patients. The SSA, SSB positive patients will be followed up for monitoring the development of Sitka symptoms, which can be tested by Sharma's test, the tear column test, and the anti-dsDNA levels should be checked for conversion from anti-dsDNA negativity to positivity. Thus, it alters the prognosis. The patients who are persistently anti-ds negative has polyserositis as an atypical feature. So if we find polyserositis not getting any cause, so we'll also think about anti-dsDNA negative lupus in these patients. So this is in summary the clinical and laboratory features of my case series. The first patient, the second patient, and third patient. I'm just going quickly through it. These are the references. And finally, I would like to thank my co-authors, Professor Shopon Sarkar, Dr. Bishwarup Mukherjee, and Dr. Supratim Ghosh. They have been with me. And I would like to acknowledge the Department of General Medicine, Jagannath Gupta Institute of Medical Sciences and Hospital, Boj, Kolkata, where I'm working for more than 7 years. Thank you, sir.
Sciences, which is located at Hyderabad, Pakistan. The abstract of my research article is the carpal tunnel syndrome is a rising issue that is less commonly enlightened by the researchers in a pregnant woman. It's an observational study which is gathered from the different hospitals from the Hyderabad. The total sample size is around 164 pregnant women with the average up to 26.15 to 5.48 were included and complete the questionnaire. The questionnaire which I will use is the Boston Carpal Tunnel questionnaire, which is a standardized questionnaire. Introduction. What is the entrapment neuropathy, or in a simple term, we can say is that a carpal tunnel syndrome is the most persistent problem in a pregnant woman. Basically, what happened in it, the compression of a median nerve occur at the level of carpal tunnel, which is formed by the carpal bones and the flexor retinaculum. The factors which are affected are most commonly the wrist injury, the swelling during the time of pregnancy, the age, which is around 40 to 60, one of the systemic disorder like rheumatoid arthritis, and multiple other secondary causes like diabetes mellitus, amyloidosis, hyperthyroidism, and other hormonal variations. Well, obesity is also the major factor that contribute towards the cause of CTS in pregnant women. Well, what are the symptoms which she were facing? Whereas the numbness and a tingling sensation over radial half. As we know, the medial nerve supplies the radial half of our hand. So the tingling and numbness is find out at the level, as well as the burning of a wrist and the loss of a hand grip. Dexterity is the familiar feature. Well, the prevalence is 62% pregnant women are estimated in a report, whereas in the further researches in US and UK, their percentage is around 5% to 7 to 16%. Whereas in Japan, in a recent report, the CTS in a pregnant woman were about 50%. In other literature review, one of the researcher Vital addressed the hand symptoms in a median nerve distribution in 24.9 women, aggravating symptoms in 51 women, distributing function in 42 women. However, interference with sleep affected 29%, and 4% women found that the pain symptoms were as severe as intolerable. It was also noted that only the 16% were treated and only the 49% described their symptoms to their doctor, otherwise remaining can neglect it. On counter to the low prevalence internationally, in Pakistan, prevalence of CTS, or you can say the entrapment neuropathy in pregnant women in general population was a frequent at 50%, which is halfway almost. However, only one state notified that the frequency of CTS in gravid women as 47.5%, which results suggest that out of 40 pregnant women, 90 women were diagnosed with CTS, but they can either neglect it or didn't disclose with their caregivers. Moreover, in Iran, a study conducted on pregnant women showed 19% of CTS, out of which 14.7 had bilateral symptoms, and its severity had 26.3%. During the first trimester, the frequency of entrapment CTS was 11%, then 26, and then 63 in second and the third trimester respectively. Meaning in the first trimester, there is a chance of 11% of CTS. In the second trimester, there is a chance, not a chance, there is reported as 26% of the cases, and in the third trimester, it were reported as 63% of the CTS. What is the significance of this research? This survey targeted to identify the frequency of entrapment neuropathy among the gravid women and to explore the potential contributing factor over it. The research objective is to assess the frequency of CTS or entrapment neuropathy in gravid movements. The inclusion criteria, the patient which I will include are those having the pain and tingling in the hand, having a positive balance test, and are the gravid women, because its research is dependent upon the pregnant women. Okay, excluding criteria, those pregnancy which having a high alert or high threat, like gestational diabetes mellitus, previous history of recurrence of the CTS. Moreover, hand or wrist injuries and fractures are also excluded, and those patients having a negative colon signs are also excluded from this survey. The material and method. As I told before, that the study is designed cross-sectional, is an observational study, and the technique which I will use is a non-probability purposes sampling. The study setting is the multiple maternal hospitals which are located in Hyderabad, Pakistan. The sample size I will calculate it through the OpenAPI software with a 95% of confidential interval, and the sample size is around 164. Data collection, I gather the information after getting the consent from the patient through the Boston carpal tunnel questionnaire, which is the one of the standardized questionnaire having a good validity and reliability for the developers and for an independent researcher. This is the format of the Boston CTS questionnaire. Okay, the data analysis, I used the SPSS 21 version, and the p-value is around 0.5. The result that I gather is shown by this table. This table is for the calculation of a biographic conclusion that in 64 women, 55 women are at the age of 18 to 22, 39% women are at the age of 23 to 27, 39 women are 28 to 33 of age, and 31 were 33 to 37 age group. Whereas according to the trimester, 33 were in the first trimester, 41 are in the second trimester, and 90 were in a third trimester. Among the study participants, majority are female in the third trimester of the pregnancy, which is around 80, and the percentage is 54.4%. Face diseases related to the problem which I am highlighting. The figure 1 shows that the most of the females presenting with a complaint of pain in hand or wrist during the pregnancy and high mild symptoms as elevated by the Boston carpal tunnel syndrome questionnaire. In this figure number 2, this one shown by the pie diagram that the number of the symptom severity is around 89.6%, whereas 10.4% are non-problematic patients. Okay, according to the result, it is apparent that those pregnant women who were in a third trimester, CT is the most common in them, with showing quite similarities with the previous studies which were conducted on this topic over the globe. Significant rate of CTS during gestation give an idea of how provoking is in the society. There are multiple authors who did research on it and shows the record that 62%, 34%, and 24.6% are the percentages that were reported about the CTS in gravid movements. In current survey, 89.6% frequency of the entrapment carpal tunnel syndrome against gravid women were in third trimester. In contrast to the other researchers, this study also excluded those pregnant women who had the gestational diabetes and other diseases of complication among the pregnancy with CTS. So the enrolled patients were small in number in this survey. In the conclusion, CTS is a frequent among women in gestational period, most probably in the third trimester. Even though it being a common in gravid women, there's bothersome syndromes during pregnancy is often treated as uncommon. This demonstrates the need to launch the prevention programs to stop it earlier by taking protective measures or treatment. What are the limitations? Due to the paucity of the awareness, majority of the patient neglected their symptoms and unsuccessfully to highlight as they considered the symptoms to be minor and completely normal at the time of gestation. On the other hand, researchers were incompetent to obtain meaningful data to support the cause. These are the references, and there are many more, and added this some of them. This is how I can manage it, but my survey is a cross-sectional study only to gather the information regarding the CTS among the gravid women. But here I can add the treatment measurement that can be taken by a physical therapist during the time of evaluation. Is that how to manage? First of all, as I confirm the diagnosis, I can advise them to wear a night splint as well as avoid prolonged positioning, which can irritate or extend the symptoms, as well as the exercises. Exercises include if the swelling is present or available at the level of wrist or hand, so the elevation and the drainage exercises.
My report shows the scientific assumptions from which the team I work in has taken its cue to experiment with the use of transformative art workshops in the treatment of fibromyalgia syndrome with the Pharmakon Art That Cures project. Fibromyalgia is a widespread chronic pain syndrome with many associated symptoms. The symptomatological picture is varied and complex and has considerable correlations with MUS value and non-specific MUS symptoms, medically unexplained symptoms, present in other difficult to classify syndromes such as fibromyalgia, which is often related to a traumatic event, either severe or short duration or mild but protracted. In the ICD-10 classification, in which little attention is paid to chronic pain, fibromyalgia is part of the painful disorders of the musculoskeletal system and connective tissue, and is considered a functional somatic syndrome, whose symptoms are the result of an altered interaction between the different systems of our organism: central nervous system, peripheral nervous system, autonomic nervous system, immune and endocrine system. Then, the IASP in 2017 established a board of pain medicine specialists who developed a classification of chronic pain that was included in the ICD-11 version as MG30 and approved by the World Health Assembly in 2019. The 2016 American College of Rheumatology diagnostic criteria leave the detection of tender points in the background and focus only on 4 points: chronicity, duration of symptoms greater than 3 months, widespread pain, chronic fatigue, and sleep disorders. The most common therapy is multimodal, patient-centered, to the point of firstly informing the patient about the complex aspects of the pathology and educating him or her in order to achieve the patient's assumption of personal responsibility in the individual management of the syndrome. The medical approach is multimodal and requires collaboration between specialists from different branches. Standard pharmacological therapy is symptomatic, therefore polypharmacological, to control the numerous symptoms present in the syndrome. Each treatment must be tailored for every patient and balanced according to his or her needs. It is compulsory to treat comorbidities. The main drugs used are listed here. Unfortunately, this therapy is often ineffective in improving the patient's quality of life, although it sometimes achieves the goal of improving some of the symptoms. In real life, this could be part of an FMS patient who follows the treatments of many specialists, similar to that of a lone navigator around Cape Horn, as rendered in a 3D artistic installation by the artist Susan Kessler in 2018. After many turns, direction and destination seem lost. It's time for a change. Seeking solutions to the problem of often ineffective therapy in fibromyalgia, we retraced the historical stages of studies of pain in this syndrome, looking for the moment when we could have used a broader vision to assess whether this could have led to new therapeutic strategies. I will show you the pathway which allowed us to find a solid scientific basis for the activities when then carried out with patients with improved results on their pathological picture. In 1998, an Italian researcher demonstrated the hyperactivation of NMDA receptors in patients with fibromyalgia syndrome. NMDA receptor hyperactivation is pathognomic of the phenomena of central pain sensitization and neuroinflammation. From then until 2017, the pain of fibromyalgia syndrome was understood to be centralized neuropathic pain. The therapy used was borrowed from the long experience of pain therapists on centralized pain. Duloxetine and tramadol, both active in turning off an NMDA receptor hyperactivation, were the drugs of choice, followed by anticonvulsants, muscle relaxants, hypno-inducers. And in fact, in many scientific studies on fibromyalgia, the one I am showing you is from 2021 Central Sensitization Phenomena Fund. An IASP board in 2014 set out the criteria for the diagnosis of central sensitization pain. TS is characterized by an impairment in the transmission of stimuli from the periphery to higher nerve centers. It is initially triggered by a tissue lesion, pathology, or stress that sensitizes nociceptors, taking the form of an increased reactivity of central nociceptive neurons to normal or subthreshold afferent inputs. These increase the reactivity in an adaptive response designed to protect us from actual or potential harm. However, if nociceptive stimuli are intense, long-lasting and/or repeated, the central neurons may remain sensitized even after the stimulus that activated them has ceased, generating phenomena such as secondary hyperalgesia and increased response to painful stimuli outside of lesion, allodynia, a response to normally non-painful stimuli, and enlargement of the receptor field. Here in the box you see the clinical features that constitute the criteria for diagnosis in red, the non-painful symptoms present in central sensitization pain. In 2017, the IASP defines nociplastic pain as the third descriptor alongside the nociceptive and neuropathic pain. You can see the definition here. The pain of fibromyalgia, such as of irritable bowel syndrome and some types of headache, and some types of chronic low back pain, is nociplastic. This pain is due to impaired nociception without any evidence of disease lesion of the somatosensory system. Here you see diagnostic criteria and clinical symptoms of nociplastic pain. It is now agreed worldwide that although central sensitization pain is one of the main mechanisms behind the nociplastic pain picture, the two terms should not be confused and are not synonymous. Here you will find a flowchart for the diagnosis of nociplastic pain. I prefer not to dwell on this today. Many studies state that both phenomena can be traced back to the neuroplasticity of the central nervous system, in which biopsychological factors have great significance: emotions, erroneous beliefs, reduced social participation, emotional distress, anxiety, depression can modify the response of the central nervous system to peripheral afferents, favoring the persistence of pain beyond 3 months after its onset. The characteristics of nociplastic pain are in fact often recognizable in patients with chronic pain. In conclusion, the clinical manifestations between nociplastic pain and central sensitization pain are very similar. In both cases, the role of environmental and behavioral factors, which can prolong the duration of pain beyond 3 months, is important in determining the deviations between phenotype and genotype and the consequent need for individualized pain medicine.
Thank you very much. And on the same topic, there is another talk or video by Claudia Villani, or both of them were supposed to speak on the same topic. Can the organizer clarify?
Sapio, who preceded me. My name is Claudia Villani, and I am an Italian transdisciplinary cultural artist and designer. Since 2018, I have dedicated myself to the study and experimentation of transformative artistic practices in the field of fibromyalgia syndrome in collaboration with Dr. Sapio. In this pitch, in addition to reporting the theoretical and
Forgive me, sir, whoever is playing this video, we can't hear her at all. Can you increase the volume? Can you increase the volume?
Katu Private Hospital. So our presentation is on access gate related lower limb fractures in children and adolescents. It's a review of injury patterns and evaluation of associated injuries. This was my MMed project. Most South African houses are fenced and they use access gates due to the high levels of crime. Access gate related fractures are frequently seen in our ER at Dr. George Mokari Academic Hospital. This then result in physical injuries, hospitalization, and missed school days for these children. This is the type of gate that we're talking about that is being used for access in the townships in South Africa. The aim of the study was to evaluate the patterns of lower limb fractures, the management options, and concomitant injuries in children and adolescents presenting with this access gate related lower limb traumas. The ethical clearance was sought. Retrospective cross-section review of 43 children with 46 lower limb fractures under the age of 12 was undertaken. This was a level 3 trauma center over a 48-month period from the 1st of January 2017 to the 31st of December 2020. The data sheet was used to collect the data, as you can see on the screen. So we went through 403 files of patients with lower limb fractures, and 43 patients were identified to have been injured by the gates, and 32 children with 35 fractures were then included, to the exclusion of 11 who, due to inadequate data. This is the age distribution. As you can see, it does look like at around age of 3.5, that is when the most injuries occur. 71.88% of children were under the age of 6. In terms of the gender distribution, males were more affected. 75% of our patients were males. The gates that were implicated in this case, we have two types of gates here. There's motorized as well as the non-motorized. So the non-motorized ones are the ones that seem to be a problem. In 93.75% of cases, it was non-motorized gates. So it'd be then the manually operated gates. And the mechanism of injury would be the gate that would then get derailed from its track, collapsing onto the child, falling onto the child. This was in majority of the cases. And the type of injuries that would be sustained is mostly femur fractures, these are the long bone fractures, followed by the open tip fib and ankle fractures, which were at the level of the growth plate. And most fractures were length unstable, diphyseal fractures. So as I indicated, these were length unstable fractures, with oblique fracture pattern being the most common. There were concomitant mild head injuries that were observed in 12.5% of patients. And most patients who would get these head injuries would have associated femur fracture. In terms of our results, surgical treatment was offered in the greater majority of our patients, 93.75% of patients. The non-surgical treatment was only in around 6.25%. The tense nail was the titanium elastic nail system. It's the method that was mostly utilized here. In terms of our complication, we had about 2.5% complication rate, which included shortening, implant migration and shortening, as well as infections. In conclusion, access gate-related lower limb fractures are less commonly observed compared to other injury mechanisms in children and adolescents. Most of these fractures are isolated diaphyseal and length unstable injuries, commonly affecting younger children. High injury prevalence is associated with non-motorized access gates. So the use of motorized gates and appropriate child supervision at home may reduce the chance of these injuries. These are just the limitations of our study. Thank you very much.
That was an excellent presentation, and your gates, as you were showing at the end of it, that they should be modified to prevent those injuries. So keep it.
And tendons and ligaments have slower healing potential due to their sparse vascularization. Conventional management of enthesopathies included rest, anti-inflammatory medication, and corticosteroid injection. Platelet-rich plasma is an autologous fraction of blood with a platelet concentration of at least 1 million platelets per microliter, or approximately 5 times that of the whole blood. As a source of growth factors, including platelet-derived growth factor, vascular endothelial growth factor, insulin-like growth factor 1 and 2, and healing cells, platelet-rich plasma offers improved rate of response in treatment of enthesopathies compared to the conventional methods. The aim of my study is to compare the clinical efficacy of platelet-rich plasma versus steroids for the treatment of common enthesopathies. The enthesopathies included in this study are medial and lateral epicondylitis, dequervin stenosynovitis, and plantar fasciitis. This was a randomized single-center 2-arm parallel group participant and SSR blinded study, which was conducted at our tertiary center in India. 100 patients aged 18 and over, diagnosed with one of the 4 enthesopathies, were recruited from November 2017 to October 2019. 50 of the patients were randomized to receive platelet-rich plasma injections, while the rest received steroid injections. The primary outcome measure was a visual analog scale score obtained pre-injection and at 1, 3, and 6 weeks. The baseline demographics were well matched between the randomized groups. There were 67% females and a mean age of 40 years. There is a significant difference in the VAS score between the platelet-rich plasma and steroid groups at 1 week following the injection. Steroid appeared to offer a faster onset of pain relief compared to platelet-rich plasma injection. But this onset of pain relief was short-lived. At subsequent follow-ups at 3 and 6 weeks, patients who received platelet-rich plasma appear to have a slower but more sustained onset of pain relief compared to their counterparts in the steroid group, who began to experience a return of their symptoms. This shows that platelet-rich plasma has a slower onset but more sustained relief of pain compared to the local steroid injection. In conclusion, we can say that platelet-rich plasma offers a slow but sustained relief of pain when administered locally at the site of enthesopathy compared to steroid. Platelet-rich plasma is thus a safe and effective alternative to steroid in the management of enthesopathies. That's the review of my literature. Thank you.
I must compliment for such a short presentation. Can I ask you which kind of steroid was used? If at all, have you used
we had a patient coming to our skin clinic with a 71-year-old man who presented with a lesion in his left middle finger, which he had for about 6 months. And in his presentation, he didn't complain from any pain or itching or any sensory or motor deficit to his finger or his hand. And there was no history of trauma to his finger or his hand. The patient didn't have any past medical history of skin cancer or a family history of skin cancer, and he didn't have any other concerning lesions in his body. He had a past medical history of hypothyroidism, hypertension, and asthma, and he didn't have any risk factors for skin cancer, including radiation, walking outdoors. He used to work indoor during his younger years, and he wasn't immunosuppressed from medication or medical condition point of view. On our examination, we used the dermatoscope to examine the lesion closely, and we find that the patient had a 1.1 centimeter ulcerated lesion on the volar side of the distal phalanx of his left middle finger. The lesion under the dermatoscope showed ulceration and telangiectasia. There was no cafe au lait spots, no evidence of neurofibromas or any other signs of neurofibromatosis. This case had been discussed in the skin multidisciplinary team, and the outcome was to excise this lesion and send it for a histological diagnosis. So the skin excision was done, and the specimen was sent for the lab, and the lab under examination showed a histological assessment of a confined myxoid tumor made up of a cylinder, elongated spindle cells arranged in a short vesicle with somewhat storiform pattern. And when using the immunohistochemistry and staining with an epithelial membrane antigen, the AMA and the CD34 was patchy, and there was no staining of S100. So the main staining was from the epithelial membrane antigen. And our lab colleagues decided that these characteristics are conclusive of cutaneous sclerosing perineurioma. The question is, what is perineurioma? So perineuromas are rare, slow-growing tumors composed exclusively of perineural cells. And the perineural cells itself are epithelioid myofibroblasts make up the perineurium. And the perineurium itself is a small translucent tubular membrane that covers and protects the nerve vesicles. So it's a layer that surrounds the vesicles of nerves. Every nerve in our body have a layer over it called the epineurium, which composed of perineural cells. Perineuromas represent a rare, distinct entity of a spectrum of nerve sheath tumors, and they are composed exclusively of an epithelial membrane antigen-positive cells. Perineuromas are classically divided into two categories according to the clinical and pathological features, including intraneural perineuromas, which are restricted to the boundaries of the peripheral nerve, and the extraneural perineuromas. The extraneural perineuromas usually arise away from the nerve itself in areas like the dermis, subcutaneous tissue, deep soft tissue, and rarely in visceral location. And extraneural perineuromas can further be divided into soft tissue perineuromas, cutaneous perineuromas, sclerosing perineuromas, reticular perineuromas, and plexiform perineuromas. The key diagnostic feature for perineuromas are the epithelial membrane antigen-positive cells and the lack of the S100 as well on the identification. And they usually, the spindle cell, they lack the spindle cell proliferation in the H&E staining as well. Perineuromas are first been described in 1987 by Trombett and Lazarus, and the majority of cases were extraneural rather than intraneural, and they are found in the trunk and the extremities of the middle-aged adults, and only a small percentage occur in youngsters. Sclerosing perineuromas, which is the main of our talk today, is most commonly found in the fingers and the palms of young adults, but have been also described in non-acral areas as well. So differential diagnosis. So when we saw this patient in the clinic, our first suspicion was this most probably skin related, and our differential was either basal cell carcinoma, especially because of the telangiectasia and the dermatoscope. Other differential from the skin point of view was squamous cell carcinoma and amelantic melanoma. Also, we included in the differential some soft tissue tumors, including giant cell tumors that we sometimes see in fingers, neuromas. But to be honest, we didn't think about perineuriomas in the beginning because it's very rare. And differential for perineuriomas itself include neurofibromas, schwannomas, solitary schwannomas, and traumatic neuromas, as we put on our first differential diagnosis, giant cell tumors, which is originally arising from the flexor tendon sheath in the fingers, and fibromas, and lastly, neurolymphomas. Our conclusion from this study that cutaneous perineuriomas is a very rare benign tumor, usually treated with excision of the lesion with a thin margin of normal tissue. And the perineuriomas are vague, still clinical. Their clinical appearance are variable and histological shape as well, and it's easy to misdiagnose and confuse with other type of soft tissue tumors. And further research in immune staining and genetic assessment is needed to aid the diagnosis of cutaneous perineuriomas. These are references that we use in our study. Thank you very much.
Thank you very much, Mohammed. That was an interesting case you shared with us. It's a rare entity, and I think once in a lifetime people may see that. But since
Yes.
you described about
Trust. Together we are presenting Fixing the Distal Radius and Ulna. Here's something new. Fractures of the distal radius and ulna are one of the most common fractures encountered by orthopedic surgeons. Often these fractures are comminuted, and obtaining proper imaging in terms of a posterior, and lateral views is troublesome, and rotational control of the fragments is quite difficult to achieve. The aim of my paper is to demonstrate the benefits of using a wrist tower and a posterolateral fibular plate while operating on the complex fractures of the distal radius and ulna. The technique is that the patient is positioned supine and a pneumatic tourniquet can be applied. The wrist tower is applied to the patient's forearm and hand to hold the wrist out to length, and 10 pounds of traction is applied. The approach to the ulna is then made along the subcutaneous border, and the shaft fragments are reduced into a single chunk and fixed with the posterolateral ankle acumen plate, which is then sized and fixed with distal screws, and the fractures reduced onto the plate and fixed with locking shaft screws. The concomitant distal radius fracture can be addressed by a standard extended FCR approach. The role of the wrist tower. The wrist tower is specially designed to provide stable traction, and in our case, we use 10 pounds of traction to the patient's forearm and hand while allowing unrestricted access to the wrist during the fixation of forearm fractures. It also provides an ease of intraoperative imaging, as can be seen in the photos that are shown in the screen. This is a schematic representation of the relative position of the patient's wrist in the wrist tower with respect to the surgeon, C-arm, image intensifier, as well as the anesthetist. The fractures of the distal radius are quite complicated to address, given that there needs to be a constant change in the position of the forearm from pronation while operating on the ulna to supination while operating on the radius. The swivel arm of the wrist tower swings around 180 degrees, allowing ease of obtaining intraoperative imaging, as well as mitigates the difficulty of constant change in the position of the forearm. The standard plates provide fixation with 1 or 2 screws into the distal fragment of the ulna. However, the posterolateral ankle plates specifically mimic the anatomy of the distal ulna, and given the low profile, they cause lesser soft tissue irritation and provide anatomical reduction with stable fixation, allowing early mobilization. In conclusion, we can say that use of posterolateral ankle plates for fixing comminuted distal ulnar fractures and the use of wrist tower are novel methods with several advantages in fixing comminuted distal radius and ulnar fractures. Sorry. Thank you.
Madhvi, this was an excellent and brief presentation.
Thank you, Prof.
My question is, I had come to Stanmore and had been with Professor George Bent.
This work between me and Professor Isabel Rosa in Portugal. So, ankle fractures have an incidence of 125 per 100,000 a year. Usually they are more associated with low energy trauma in patients with more than 50 years, usually in females, or in patients, in male patients with less than 30 years due to sports or traffic accidents. In maleolar fractures, it is very important to see the contribution of the deltoid ligament for the stability of the ankle, because it works as a medial stabilizer in the biomechanics of the ankle, because it limits the anterior, the posterior, and lateral talar translation of the ankle. Usually the deep bundle of this ligament is the most important contributor for ankle stability. It is important to identify a deltoid ligament injury, and that's why we try to start this work and to see if we could check the injury of the deltoid ligament before the surgery with the specific tests. And we do that by measuring the tibiotalar space, the medial tibiotalar space, in two ways. So when we have like a gravitational X-ray, or if we do the manual stress test, it is important to see if the medial tibiotalar space has more than 4 millimeters or more than 1 millimeter greater than the superior tibiotalar space in a radiograph at 10 degrees of internal rotation, which is a predictive factor for injury of the deep bundles of this ligament. It is also important to see if in these cases the clinical decisions are based in like a few millimeters differences, usually 1 to 2 millimeters differences, and there's need for a good agreement in measuring this tibiotalar medial space. So what we proposed for this study is we had two groups. One of them was under a manual stress test. In a manual stress test, we do like a forced external rotation and supination of the ankle to see if the tibiotalar, the medial tibiotalar space, it opens. And we check in the X-ray how much is this opening, or we can do like a gravitational stress test that was like the gold standard for this procedure, in which we can see with 10 degrees of internal rotation of the ankle if we have like opening in the medial tibiotalar space. So the objectives of this work are to see if these tests are enough to diagnose a deltoid ligament injury in lateral fractures, to see if it has validity in therapeutic decision, to compare the manual stress test to the gravitational stress radiograph, and also to see the predictive value for deltoid ligament injury when we have like an opening of the medial tibiotalar space more than 4 millimeters or more than 5 millimeters. So for this, we started an observational longitudinal study, a prospective comparative cohort with a population of 105 patients, initial population, with maleolar fracture that was seen in the emergency room between the period of February 10th, 2016 and November 13th, 2017. And from this population, we had like a number of 65 patients who were submitted to the gravitational stress radiograph, which was the gold standard, and the manual stress test. For this study, we had like inclusion criteria of skeletal maturity, lateral maleolar fractures with suspected deltoid ligament injury, medial maleolar avulsion less than 5 millimeters, shortening more than 2 millimeters, and a rotational deviation. We excluded the patients with previous maleolar trauma, isolated medial or posterior maleolar fracture without deltoid ligament injury, patients operated by other colleagues, patients that had 15 days or more after the acute traumatic episode, or transferred to another institution. So from these two groups, the first one with manual stress tests were divided in the ones that were exposed and non-exposed. The exposed ones had the deltoid ligament injury, and the non-exposed didn't have that injury. The second group, gravitational stress X-ray, also a difference between the exposed and non-exposed. So here are the radiographs where we can measure this medial tibial space. The measuring is made like 0.5 centimeters below the superior border of the articular surface of the talus, and it's like here in the first X-ray we can see it in the gravitational. In the other one, when we are doing the manual stress test, and the results that we obtained was from the 65 patients. 25 of them were male patients, 40 of them female, with a mean age of 50.7 years, with a standard deviation of 17.5. The first group, 60 patients had instability, and in the second group, 62 patients had instability. From the first group, we had 24 in the exposed with the tibiotalar medial space more than 4 millimeters. 36 of them with more than 5 millimeters, and only 5 patients with no injury or with less than 4 millimeters medial tibial space. In the second group of the gravitational X-ray, we had 35 of them with more than 4 millimeters of medial tibial space, 27 with more than 5 millimeters, and 3 of them with no injury. Here we can see, due to the measurings that we've made afterwards, that the manual stress test in the first group had a sensitivity of 97%, with 100% of specificity, and also a positive predictive value of 100%. The negative predictive value was 60%. For the exposed group, the medial tibial space was of 6.3, with a standard deviation of 3.2. And in this one, also the non-exposed group, medial tibial space of 3.3 with a standard deviation of 0.6. All of this with statistically significant. In the second group, the exposed group added a medial tibial space of 5.9 with standard deviation 3.4, and the non-exposed group was at a medial tibial talar space of 3.1 with a standard deviation of 0.6, also statistically significant. In this one, and this is the most important thing that I think about the work, it's that we can see if the gravitational stress X-ray at a less specificity, only of 60% compared with a manual stress test that has at a 100% of specificity. And in the second group, the positive predictive value of 97 and negative of 100%. So also due to these results, we could conclude afterwards that the medial tibial talar space, if it was more than 5 millimeters, although all of the values that we evaluated were of 100%, and if it was more than 4 millimeters, we had a reduction of the sensitivity to 91% and a negative predictive value of 6%. When analyzing the inter and inter-observer variation, we had like an agreement of 95% in the inter-observer variation in the first group, and of 88% in the inter-observer variation, also statistically significant. In the second group, there was an agreement of 97% inter-observer and 91% inter-observer. Also, for these two groups, it is important to refer that they were evaluated for correlation, and we had like a collinear correlation between the two groups with a Pearson correlation coefficient of 0.7. And even for both that, we could check that is validity it exists. So for the discussion, we could see that lateral malleolus fractures are the most common pattern of malleolar fractures. And if we have a medial ligament complex injury, they are considered unstable. The gravitational X-ray is recommended, but is as reliable as the manual stress test. The medial tibiotalar space measure in determining the integrity of the deep deltoid ligament is the most important. And we have variability in measures because it depends of the person who are doing the measures, and we will also always have that variability. We also have the problem of the false negatives that are treated conservatively, and the false positives that are operated with these tests. There is an intra and inter-observer agreement with a kappa more than 0.75. This study, as all of the studies, has limitations. It depends on the images and the acquirance of the images. It depends on the experience of the imaging technician, the patient cooperation, and it also because it's difficult to standardize the force applied in a manual stress test. Sometimes it opens a little bit less than what we were expecting, even if we have a deltoid ligament injury, and there are also need for more comparative studies. In conclusion, if we have a tibiotalar medial space more than 5 millimeters, it has a high sensitivity, specificity, positive predictive value and negative predictive value in assessing deltoid ligament injury. Both tests are effective tools in evaluating deltoid competence and could be decision makers in lateral malleolus fractures. Thank you.
Thank you very much, sir. It was a very nice presentation. But in what way does it differ that if we get a CT scan, if necessary, MRI, to study all this rather than doing all this jugglery?
Urgent treatment is necessary to preserve the viability and the function of the finger, and usually a surgical washout. So what's canaval sign? We have 4 canaval signs, 2 of them you see and 2 of them you examine for. So the two you see is fusiform swelling of the finger, and the other one is flexion deformity of the finger. And two you examine for is, one is on pain on palpation of the flexor sheath, is the volar side of the finger, and the other one is extension, pain on passive extension of the finger, which is the most sensitive sign. Okay, our aim from this audit was to try and apply the British Society of the Surgery of the Hands standards to our trauma care. And we've done two cycles of the audit. The first one was between May 2021 and November 2021. And second cycle was between December 2021 and May 2022. And the standards of the PSSH guideline talked about the first aid treatment and referral pathway, the consent and the principle of shared decision with the patient, the operative management requirement and timing, and the operative technical aspect, and the post-operative follow-up and the physiotherapy. And I'll just say a few words about each of these standards. On the first aid treatment and referral pathway, whenever you see a patient in emergency department or suspecting flexor sheath infection, you have to elevate the patient hand, splint the patient in a position of safety, start the patient in empirical antibiotic, and refer the patient to appropriate unit where a hand surgeon is present. And most likely, these patients will require surgery. A few amount of these patients can be treated with IV antibiotic and close monitoring. Regarding the consent and the principle of shared decision making, you have to discuss with the patient the risk and the benefit of surgical and non-surgical options. And you have to outline for the patient that this is not a one and done. It's not going to have a surgery and then go back to his normal life or work. Is going to have a rehabilitation process, and we have to discuss with him the outcomes of these infections. Usually occupational hand therapists, and they should be present for the treatment of a patient with flexor sheath infection. And for the few patients that are treated without operation, they have to be closely monitored. And if they are getting worse, they have to have surgery. Operative and management requirement and timing. So most of the cases are treated with surgery, and the surgery have to be done in an urgent basis as soon as possible, with ideally within 24 hours of the decision to operate, and have to be done within the safe working hours. As long as the patient is not septic or unwell, we usually do these cases in between 8 a.m. in the morning and 8 p.m. and we don't do it after that unless the patient is unwell. And the usual equipment that we use are the standard equipment for flexor tendon injuries. So the technical aspect in doing the surgery itself is usually a washout, and we use a high volume of normal saline plus or minus local antibiotics. And we usually give the normal saline and antibiotics through either a pediatric catheter or a cannula, putting into that flexor sheath. And we access that flexor sheath with two incisions, one in the volar side of the distal palm over the A1 pulley, and the other incision over the distal interphalangeal joint over the A5 pulley. And we have to make sure that these fluids that we're putting in are in the flexor sheath, they're not outside the flexor sheath, because the high volume and the pressure can damage the structures inside the finger. And whenever we find a purulent infection where there is frank pus in the flexor sheath, the recommendation is for the patient to go back for another washout in 48 hours. A therapy requirement: the patient needs to have an early access to the hand therapist, and they need to have supervised early active motion. And this early active motion will maintain the patient's range of motion, reduce the edema, and prevent adhesion. And these are typically commenced in the first day after the operation. And the recommendation from the PSSH is that the patient should be offered a therapy for at least 6 weeks after his operation. Our audit was a retrospective review of all patients listed for trauma theatre for a flexor sheath washout for the first cycle between May 2021 and November 2021. Second cycle between December 2021 and May 2022. All patients under the age of 16 were excluded. And the points that we looked for in these patients' documentation were the Canaval signs scoring, the use of a splint in the position of safety, administration of the antibiotic within the first 24 hours, documentation of information given to the patient, and the time of surgery, as well as the microbiology confirmation of the infection and intraoperative documentation of the steps of the surgery. And did these patients had second washout or not? And did these patients receive hand therapy? And was that offered for at least 6 weeks? And what was the total active motion of the digit after the finish of the physiotherapy? And was there any rupture of the tendons as a complication from this infection? So we did 2 cycles. The first cycle we had 11 patients. Second cycle we had 16 patients. And we looked at the Canaval sign, and 75% of the patient in both cycles had 2 or more of the Canaval signs. In offering the splint, in the first cycle, 36% of patients have been offered the splint. In the second cycle, 12.5% have been offered the splint. And the recommendation from the standards are we have to offer it to the patient. The patient doesn't need to have the splint, but we have to offer it to them. And if we don't document, it's not going to count as we offer it. So most of these patients that they didn't have the splint, it was just not appropriate documentation rather than they didn't have the splint. Antibiotic, 90% of the patients in the first cycle had antibiotic within the first 24 hours. 88% in the second cycle had antibiotic within the first 24 hours. And there are only 2 patients in the second cycle who didn't have the antibiotic. And the reason was both of patients refused antibiotic. Documentation of the operative and non-operative risk with the patient. 1 patient in the second cycle didn't have a proper documentation, and all patients in the first cycle had proper documentations. Say of the 16 patients on the second cycle, 14 went into surgery, and of the 11 patients on the first cycle, 5 went into surgery. Say intraoperative documentation, 3 of the 14 patients who had surgery did not have a proper documentation, and 2 out of the 5 who had surgery in the first cycle did not have proper documentation. Say of the 14 of the second cycle who went for surgery, 13 had their operation within the first 24 hours of the decision making, and 4 out of 5 had their operation within the first 24 hours of the decision making. 8 of the 14 had second washout, and 1 of the 5 on the first cycle had second washout. In the second washout, there's 2 patients didn't have surgery. 1 patient refused the surgery, and 1 patient did not attend. And the 1 patient who had his operation after 48 hours, 1 patient had his operation within 48 hours. Regarding the microbiology, say microbiology, 50% of the samples that was sent after the washout didn't show any growth. 36% showed positive microorganism, and 2 samples were rejected. And regarding hand therapy, 10% of the 14 patients in the second cycle who had the surgery was seen in the second day after the surgery and had follow-up for 6 weeks. In the first cycle, 2 patients of the 11 patients in the first cycle were seen in the next day and have been followed up for 6 weeks. Our outcome from this audit is that from the second cycle, 12 patients of the 14 patients who had the surgery had good range of movement at discharge, comparing with 3 patients out of 5 in the first cycle. 1 patient of the 14 patients had restricted range of movement and had 4 washouts. 1 patient had an amputation after 7 washouts. Comparing with 2 patients out of 5 with restricted range of movement at discharge. We didn't have any patient who had a tendon rupture in both cycles. Our conclusion is that documentation improved, but we still can improve and meet the standards. Offering the antibiotic in the first 24 hours has improved between the first and second cycle. Our surgical intervention within the first 24 hours of presentation have improved as well. Our hand therapy within the first day after the operation and follow-up for 6 weeks has improved as well. But we still have some areas that we can improve in, offering the splint, or at least the documentation of that the splint have been offered, documentation of the benefit and the risk of the operation, operative and non-operative management have to be better, and sampling of microbiology samples that sent from the lab have to be labeled correctly, and we have to focus on that. Our recommendation is we need to offer splints, we need to do proper documentation, we need to involve seniors before listing patients, because some of these patients have been listed for surgery and counseled on the day of the operation because the senior surgeon didn't think these are proper plexus sheath infections. We have sent these presentations through emails to all the staff in the plastic surgery department to educate and increase the knowledge about plexus sheath infections. Thank you very much.
Thank you very much. That was an excellent presentation on a very difficult situation of having tendon sheath infections, and you have shown wonderful way of doing treatment for that.
Thank you.
I go into what exactly the SPARE approach is. I'm just going to give a bit of background into into the project. First off, according to the National Hip Fracture Database, in 2022 there were approximately 70,000 patients who sustained hip fractures in the United Kingdom. And again, according to NHFD data, annually there are about approximately 30,000 patients who undergo hip hemiarthroplasties. To perform hip hemiarthroplasties, there are a number of different surgical approaches that can be used. These include the medial approach, anterior, anterolateral, direct lateral, or posterior approaches. In the United Kingdom and in our trust and generally in the United Kingdom, the two main approaches that are used for hemiarthroplasties are the anterolateral and the posterior approach to the hip. Now, the difference between the two, there's a lot of debate around it. The suggested benefits of using the anterolateral approach is that there's a reduced risk of dislocation. But the disadvantage or the suggested disadvantage is that because with an anterolateral approach, there's a lot more soft tissue dissection compared with the posterior approach. And so there's a suggestion that that reduces post-operative mobilization and mobility function. And so for the posterior approach, the opposite is true. Is the suggested disadvantage is that there's increased risk of dislocation, but there's better improved post-operative mobility function. And a study by Hongisto et al. In 2018 suggested that those things were true. And NICE guidelines actually suggest that hip hemiarthroplasty should be done with an anterolateral approach versus a posterior approach, but there are still people who use the posterior approach for hemiarthroplasties. Now, moving on to the SPARE approach. So the SPARE approach stands for sparing piriformis and internus and repairing externus. And what exactly the suggested benefits are is that they suggest that they result in the benefits of both the posterior and the anterolateral approach, in that they are supposed to spare the short external rotatus, which results in less violation of the short external rotatus, which then is supposed to result in less or improved post-operative function. And it's supposed to also result in improved or reduced risk of hip dislocations. And the approach was actually first described by Hanley et al. In 2017. So to actually perform the SPARE approach, this is how it's done. So if you look at the picture at the top left, this is the annotated image of a intraoperative image of the left hip. And you can see the short external rotators. So from left to right, P is the piriformis, I is the obturator internus, along with the superior and inferior gemelli. E is obturator externus, and Q is quadratus femoris. The spare technique goes through the interval between internus and externus. And so how it's performed is a blunt retractor is inserted under internus and piriformis. And then the externus and the quadratus femoris is dissected to visualize the posterior aspect of the capsule. And then that's where the capsulotomy is performed. And then from then on, it's the procedure is the same as any other hip hemiarthroplasty with a femoral neck cut, removing the femoral head, and so on. So what we did was we wanted to look to see whether the spare approach actually does have improved outcomes compared to the anterolateral posterior approach. And so we did a single center retrospective study. We looked at all hip fracture patients who had hip hemiarthroplasties between October 2021 to August 2022. The primary outcome measure that we looked at was the rate of periprosthetic hip dislocations. And the secondary outcome measures that we looked at were post-operative time to mobilization and the duration of surgery. In that period, we identified 43 patients who underwent the spare approach, 97 who had the anterolateral approach, and 54 who underwent the posterior approach. And what we found, my graphics for some reason isn't coming up here, but what we found was that in the spare approach, there were no patients who had any dislocations. Anterolateral approach had 2% of patients had dislocations, and in the posterior approach, 3.7% of patients had dislocations. But when we did our statistical analysis, we found that the differences weren't statistically significant. We then moved on to mean surgical times. Again, I don't know why the graph isn't showing up, but what we found was that the spare approach, the mean surgical time was 74 minutes, anterolateral was 79 minutes, and posterior approach was 71 minutes. For this, the differences were significant or statistically significant, but clinically, the numbers were quite similar, so they weren't actually clinically significant. And finally, looking at mean return to mobilization. For the spare approach, mean return was 1.4 days. For the anterolateral, it was 2.5 days. And for the posterior approach, it was 1.9 days. So it showed that the spare approach did show improved time to mobilization, but again, this wasn't statistically significant. So from the study that we did, it showed some evidence that the spare approach was a safe alternative or a safe technique to be used for hip hemiarthroplasties. Again, there were no dislocations. It showed good postoperative function, and the time taken to perform the procedure was similar to the other approaches. But from the study itself, there were a number of limitations. It was quite a small sample size. I think there were less than 200 patients overall. Second, there was no standardization of surgeons. So all the operations were performed by a registrar level surgeon, but not all of them. Some of them were supervised by a senior consultant. Some of them were done independently. And also the registrar grades who would perform the operations were of different levels, and so would have had different varying levels of skill and technique. And so that might have been a confounding factor in the results that we found. And finally, the patients that we identified were, for each group, were unmatched. So they were not matched for things like age, gender, preoperative mobility function, or their comorbidities. And so again, those may have contributed or resulted in more confounding factors, because one group may not have been the same as the other. So I think this study shows, again, provides some supporting evidence for the use of the SPARE approach, but I think more research needs to be done, accounting for the limitations that I've suggested, to provide stronger or more conclusive evidence that the SPARE approach does actually improve post-operative function, or improve or reduce the risk of dislocations. Thanks for listening. These are my references. If anyone has any questions, feel free to ask.
Thank you very much, Darren, for your wonderful presentation. And what I want to ask you is,
is between 6 to 17%, depending on the zone of injury and the digit involved. In our University Hospital of Plymouth Plastic Surgery Department in 2014, we have done an audit which showed that our re-rupture rate was 11%. And at all costs, we need to avoid secondary repairs, because it's a very difficult operation, it's a complicated, and it has very poor outcome for the patients and functional impact. So the aim of our audit was to identify incidents of secondary surgical repair for re-ruptured tendon and to establish any common variables in re-ruptured patients, including surgical techniques, suture type, surgeon seniority, and the contributing mechanism of the injury. And we needed to do, lastly, is to consider the short and the long-term outcomes of the tendon re-repair. So our method was a retrospective review of patient identified between May 2022 and May 2023, and we reviewed the case notes for these patients. A little bit about the repair of tendons. Usually when we repair tendons, we use two techniques. One is core sutures and the other one is epitendinous sutures. Core sutures are the sutures that you put inside the tendon, and the aim of them is to transmit the longitudinal tension and to prevent gapping formation. And typically we use a 3/0 sutures. When we're doing flexor tendon, we use 3/0 Prolene. When you do an extensor tendon, it's either 3/0 Prolene or a BDS, depending on the zone of the injury itself. And most of the time, you'll not have to be inside the tendon. And the gap, so where you put your point of the stitch, have to be 1 centimeter from the edge of the tendon. And the experimental evidence of that have been done showed an optimum purchase of your suture if you put your stitch between 0.7 to 1 centimeter from the edge of the tendon. And if your suture is slightly more volar than dorsal surface. There are 2 or 3 types of the strand numbers. We have 2 strands, 4 strands, and there is 6 strands as well, but it's less commonly used. The most common 2-strand suturing that is being used is a modified Kessler, which is the one in the middle, number B. And we have 4 strands. The most common ones that are being used in my department are the crochet, which is number B, and the Adelaide sutures. The other type of suturing that we use for the tendon repair is the epitendinous suture. And the aim of this is to create a smooth outer gliding surface, because when you repair these tendons, especially when you're doing a flexor tendon zone 1 or zone 2, the space that the tendon is going to glide in is not big. There's a limited space, and that's why your surface have to be smooth so that the tendon don't catch on the other structures. And the other benefit of these epitendinous sutures are to increase the strength of the repair by up to 50% and increase the gap resistance. So in our audit, we between May 2022 and May 2023, we found 142 patients who had flexor tendon repairs and 243 patients who had extensor tendon repairs as a primary repairs. And the overall failure rate was 2.8. we had 12 tendons that have gone for secondary repair in 10 patients. Patient demographics, the mean age of the patients was 41.5. 90% of patients were male, 90% of patients were right hand dominant, but 80% was the hand affected was a non-dominant hand. So 90% was right hand dominant, and the hand that was affected was their left hand. 10% of the patient had depression. We were not sure if that's related. Results, so 80% of these patients who had secondary repairs had their injury included with a sharp blade, and 20% with a blunt trauma. The average time of from initial injury to the initial repair was 2.22 days, and the average time from the initial repair to the re-repair was 13.5 days. And the mechanism of the re-rupture, most of the patient had another injury, and one patient had an infection. We had 10 patients who went back for re-repair, and 10 patients with 12 tendons. 6 of these tendons who had re-rupture in their primary repair, they were repaired by 3 or core sutures, 5 of them with 4-strand repair, and 1 of them with 2-strand repair. 2 of these patients that came back had 4 or core sutures used, and both of them had 2-strand repair used. 2 patients didn't have any documentation about what core sutures have been used. 6 of these patients that came back, their injury was at the level of zone 2 flexors. 7 of these patients have been done by registrars, 3 of them have been done by consultants. And the 4-strand repair have been used more than the 2-strand repair. So these are the patients that we have examined, and the most important information that we found is that 60% of these patients had their injury in the flexor zone 2 area. Our conclusion from this audit was we did have a good re-rupture rate of 2.8, and we need to do a better documentation, especially when documenting which sutures and which type of repair have been used to repair the tendon in the primary stage. Senior surgeon should be present, especially in zone 2 flexor injuries, because these are the most difficult and the most tricky surgery to be done. So it can be done by registrar, but the consultant have to be there. And we're aiming to represent our re-audit most probably next year. These are my references, and if anyone has any questions, I'm happy to answer them. Thank you.
Thank you very much, Mohammed. Is it mandatory to take sutures more on the ventral aspect rather than going middle or posterior so that we preserve the blood supply?
So
and the Hospital Albert Einstein, both are in São Paulo City, Brazil. First of all, I
want 42 slides at the bottom. Please hide them. Show only your presentation.
Is it okay? Is it?
No, it is not okay. At the bottom, I can see your slides. I don't want that.
You can see that?
You have to make your slide in full screen.
Yes, I did it, but I don't know why it's not in full screen.
I want to tell the organizers that I cannot teach them how to do a PowerPoint presentation. This is the way, and then you make it full screen. This is it. Now, it's done.
That's okay.
I'm not a school teacher, okay?
Okay. Well, first of all, I would like to talk about correction of bone deformities in the 3 planes by hemiphysiodesis in mature skeleton. It's called guide growth, and it's an alternative treatment for less chance of complications, less aggressive than osteotomies, and with better, quicker recovery. It's frequently used in the coronal plane to varus and valgus correction, in the sagittal plane also to anterocurvatum knee treatment, and more recently to rotation deformities correction also. First, hemiphysiodisis was initially utilized by Haas, Blount, and Clark in the 40s, and followed by Mettezo in 1998 and Stevens in 2007. In the 40s, Blount described the use of staples to achieve guide growth, and more recently, Mettezo used cannulated screws through the growth plate, and Stevens gave a new life to this treatment, replacing the rigid Blount staples by plates whose screws present a movement during the correction of the deformity, and this plate was called 8 plate based on its frontal shape. These are the instruments designed by Blount for hemiphysiodisis, with smaller staples for tibia and larger ones for femur. And the first guide growth treatment to correct varus and valgus were described by them, by Blount and Clark, but the staples present some problems sometimes, such as extrusion or brockenage of the staples. Stevens adapted Blount's initial idea by replacing the staples by a plate whose 2 screws follow the bone correction, while the growth plate increases in size, forming an angle between the screws from 0 up to 40 or until to 70 degrees. Here you have an example of a valgus knee deformity correction caused by a osteochondroma of the medial tibia, proximal tibia, using a Stevens 8-plate hemiphysiodisis technique. Mettezo and collaborators presented in their paper an alternative way for hemiphysiodisis using a cannulated screw that goes through the peripheral portion of the growth plate on the convex aspect of the deformity to correct it. As the technique was performed on patients with skeletal inactivity to pre and to teenagers, they used screws with thread diameters up to 7 millimeters thick. Mettezo described this hemiphysiodisis technique for distal femur and proximal tibia correction of varus and valgus in the coronal plane. Here is demonstrated the correction of an idiopathic bilateral valgus knee by medial distal femur hemiphysiodisis using Mettezo technique. Recently, Mettezo published an interesting paper that shows the rotation correction of distal femur by a guided growth through 2 cannulated screws, angled one to each other, one above and one another below the growth plate, and joined by a flexible steel cable that crosses through both screws. This technique uses 2 guide wires to introduce by a circular apparatus, like you can see in the right figures, to put the screws angled over and below the growth plate. Here you have, you can see it's Mettezo figures, it's not for us. By fluoroscopy, the 2 screws connected by these 2 flexible cable, and the radiographs down to the left are showing the decreasing distance, the increasing distance between the 2 screws during the patient's growth. And so the computerized tomography at the right side in the bottom can show you that demonstrates the decreasing angle between the screws, and distal femur goes together, correcting the rotation. Well, in sagittal plane, the knee can be in anticurvatum or recurvatum, and Stevens described anterior femoral hemiphysiodisis technique to correct anterocurvatum knee using 2 8 plates placed on the anterior distal femur growth plate. Here you have an example of a patient with rheumatoid arthritis taken to a anticurvatum knee. And the corrections was achieved by anterior epiphysiodesis of distal femur with 2 8 plates on the anterior aspect, like you can see here. And you can see on the left, before the treatment, the deformity, and to the right, the results after the treatment. General recurvatum is in a cell also had, recording again, she also had ligamentar hyperlaxity taken to a recurvatum left knee, like you can see here in the middle, and she was, it was also seen about 35 degrees of deformity. At that time, she was then submitted to another surgical treatment to right proximal tibia epiphysiodesis with 2 8 plates, 1 medial and 1 lateral, to decrease the leg length dispersion. At age of 11, the recurvatum left knee deformity went to 40 degrees and was associated to a rigid equinus left foot that leads to a great impact on the patient's. Here you can see a community video of the patient showing her limping gait. When she stands on the left foot, you see the knee bent to posterior. Then the patient was operated by this new technique to posterior epiphysiodesis of the distal femur to treat the recurvatum left knee. In the operating room, the patient was in a dorsal or horizontal position, and 1 centimeter longitudinal incisions parallel one to each other when made on the anterior aspect of the distal thigh. And we did a blunt section through the quadriceps muscle to achieve the anterior cortical wall on the distal femur to the proximal to the glove plate. The epiphysiodesis was done introducing 2 guide wires from proximal and anterior to distal and posterior, from distal anterior femur, from the distal anterior femur to the gross plate, crossing it next to the posterior cortical wall. Then 2 4.5 millimeters diameter thick cannulated screws were inserted to the posterior area of the distal, medial, and lateral femur condyles, like you can see here in this OR vision. And you can see the guide wires and the 2 screws going through the ghost plate. It's important to emphasize the need of monitoring at a short time intervals about each 4 months to define the exact moment to the screw removal, avoiding overcorrection. 1 year and after the surgical treatment that was done, the knee deformity was completely corrected by the guided growth that's demonstrated on the right radiography. And here you have the patient clinical appearance after removing the epiphysiodesis. Here we have another community video showing her improvement on the patient gait. You can see when she is standing on the left foot, that is equinus, the knee do not bend much to the posterior part. The patient before and after the removal of the distal posterior femoral epiphysiodesis with correction of the recurvatum knee deformity. We have a follow-up of 3 years at this patient, and there was no recurrence of the knee deformity. She is growing not much. She's 14 now, and after the correction guided by the growth treatment, it was okay, like you can see here in this X-ray. Despite the rigid equine foot that imposes a lever arm on her knee, taking it to a recurvatum position trend. We have a total of 5 patients with genorecurvatum treatment caused somewhat of arthroporosis and also spastic cerebral palsy, and this generalized ligamentous hyperlaxity that you have seen treated with the posterior distal hemiphysiodisis. It's very difficult for patients, but genorecurvatum is not, it's a hair deformity at the knee. You can see another example, another patient with arthroporosis treated with posterior hemiphysiodisis of the distal femur. It had this recurvatum by the pathology of arthroporosis, and at the right you can see the radiography of the recurvatum knee total correction after removal of the screw. This patient had 2 years of follow-up. Another alternative for treatment of recurvatum knee is described by these authors with a posterior supracondylar osteotomy, closing osteotomy, and of course it's more interesting. And there is another choice of treatment that is shown in literature of treatment of recurvatum knee and reporting high tibial osteotomy technique with opening bone wedge, and the authors describe that the necessity of replacing the anterior tibia tuberosity proximally because the anterior aspect of the tibia increased. This novel surgical proposal is minimally invasive and a reversible method with low applications rate. Of course, we have just 5 patients. Do not require postoperative immobilization and allow the patient start walking on the day of the surgery and have a fast return to their regular activities. This guided growth technique is an alternative treatment for the correction of the recurvatum knee deformity instead of osteotomies of the distal femur or proximal tibia that are, of course, more aggressive treatments and potentially with more complications. Thank you so much. Here's my email.